Today we have three speakers. We have Matt Wagner, and he is currently a second-year GynOnc fellow here, and he's in the department, obviously. Completed his residency here, and he's going to tell us a little bit about what he's been up to during his fellowship. Ushma Patel is a second-year Urogyn fellow here. She completed her undergraduate studies at Marquette and medical school at Loyola, and she has interest in global health and urinary incontinence. And then Erin Bailey, who is our MFM fellow, who's special to me because I'm an MFM, but and I've done a lot of work with her too, but she's going to be talking more about placental accreta type spectrum stuff. But she has been actively growing that program with Dr. Beninati, and that'll be fun to hear about. And she'll be joining us as faculty, so that'll be exciting. So without ado, I will turn over the series to them. We can have some conversation, and hopefully we also dream that these lead to like other collaborations with other people. So that's it.
Hey guys, you get me again. Sorry, twice in a month. So I'm Erin Bailey. I did just a little QI project looking at the cesarean hysterectomies for placenta accreta spectrum here at our institution. So if you'll bear with me for about 10 minutes, we'll kind of go through what I was able to find. So specifically, this was looking at postpartum depression, pre and post development of a comprehensive PAS center at a single academic institution. I have no disclosures. Super briefly, some background. So prior to really Dr. Beninati joining the program, diagnostic imaging and diagnosis was made by MFM in our ultrasound center. Counseling was usually done at the time of diagnosis by whatever MFM had found the accreta or concern for an accreta. Surgery was often performed by gynecology oncology, which, as all of you know, is not actually based at our birthing center hospital, which makes it just a little bit more complex in terms of surgical planning to have our gynecology oncology colleagues travel over from their home institution at UW. And then urology was not regularly involved in the care at that time. And then when Dr. Beninati joined faculty, he initially joined in 2020, but only part-time as he was finishing his critical care fellowship. So most of this actually got off the ground in 2021. Now what we do is that there's a targeted ultrasound in the MFM ultrasound unit, similar to before, but there's now a standardized consult with the PAS team. So it's usually either myself or Dr. Beninati. We actually get an MRI on all of our concern for accreta cases, and this is actually per urology recommendations and references. One of the unusual things about our program compared to others across the country is that we have Dr. Frank Lynn, who is a urologist who did a female pelvic floor fellowship following urology, who has a special interest in these cases, and so acts as our additional team member, and he really likes the MRIs. So that is why we get them here for everybody. We do a standardized anesthesia consultation. The timing of that sort of depends on timing of delivery. All of the surgeries are scheduled with the PAS team. And then we do offer both transfer of care or shared care options for patients who don't live in the area. And we've standardized that process as well. And then we've developed checklists for both scheduled, urgent, and then also emergent cases. And those checklists include a standardized checklist for all of the antepartum care and prenatal care, both for patients who are in our prenatal clinic and those that we do shared care. And then we have urgent and emergent checklists for patients who end up needing to be delivered in an unscheduled fashion. We do neonatology consultations if the delivery is anticipated right around 34 weeks, or if the patient desires. And then, as I mentioned, Dr. Lynn is involved in all of our cases and places stents for all of them. So the objective for this was to evaluate if maternal postpartum depression scores were improved following the implementation of a formal placenta accreta care center. Looking at our methods, this was a review of all cesarean hysterectomies performed for concern for PAS at a single institution over the previous 5 years, so from 2019 to 2023. So this doesn't include any of the CHIS that were performed for ATNI or other indications. It also excludes anyone who was a concern for an accreta, but didn't ultimately end up with a hysterectomy. The data was extracted from a large database. So we use the PeriData database for those of you who are familiar with it. For those of you who aren't, it's a wonderful resource that we have here. And then we performed a retrospective chart review for the remainder of the data collection. I determined that patients were considered part of the placenta accreta care center if they were referred and counseled antenatally, and they completed the PAS surgery checklist, and then also if the surgery was performed by the PAS team. Our primary outcome was Edinburgh Postpartum Depression Survey scores at 6 weeks postpartum. And then secondary outcomes that we looked at were blood loss, distance traveled to the hospital, operative times, transfusions, surgical complications, ICU admission, and then pathology. Two-sample t-test was performed for continuous variables, and then chi-square Fisher's exact was used for categorical variables. Significance at 0.05 was assessed for all outcomes without adjustment for multiple comparisons. And then ArcGIS was used for spatial analysis for referral distance. Moving on to results. So this graph is looking at 2019 to 2023. So 2019 is on the far side and 2023 is on the near side. And then in this first graph, we have the total patients diagnosed with PAS. This is just looking at cases over time. You can see that we did see a significant uptick starting in 2021. And actually, as of today, we've done 2 more cases in the last 72 hours. So this would be 2 more for 2023 that I haven't had time to update. And then the next graph is looking at patients diagnosed with PAS and unplanned deliveries. So there's some data that if patients can have a planned delivery, outcomes are improved, which I think is not probably surprising to any of us that have been in an unplanned accreta case. And you can see that overall, those numbers relative to the total numbers have decreased over time. And then when we look at scheduled and planned hysterectomies, you can see that those have increased over time. Looking at baseline demographics, we see that there is no significant difference in maternal age, gestational age at referral or at delivery, or BMI. We do see that the patient demographics show that patients after development of this program are more racially and ethnically diverse. And then we do see that there's a greater proportion of patients that have had 2 or more prior C-sections since development of the program. Looking at referral locations, so the graph on the left is from 2019 to 2021, and the graph on the right, or the map on the right, is from 2021 to 2023. This map actually is only run through, I believe, July of this year, so has actually expanded quite a bit. We've had several referrals from Northern Illinois since this time, but you can see that our referral base has expanded pretty significantly over the last several years. Looking at mean EPDS scores, so this is the mean EPDS score at the 6-week postpartum visit. So you can see for all of the rest of the graphs, gray is for standard care, so not in the placenta accreta care center, and red is for the PAC patients. You can see that they aren't statistically different. The patients in the standard care trend to be a little bit higher, but this was not significant at P equals 0.06. Often EPDS of 13 is considered a significant score. So anyone who scores greater than a 13 has concern for postpartum depression. So when we actually look at patients who have an EPDS score of 13 or greater, we see that there's no difference at all between the 2 groups. When we look at travel distance, this is in kilometers. We see that patients travel significantly further after the development of this program at 39 versus 71 kilometers. So pretty significant, almost double. Looking at placental pathology, so placenta accreta spectrum is graded on a grade 1 through 3, 1 being the least invasive, 3 being the most invasive. And we can see here that there's no significant difference, although certainly trends to be a greater proportion of grade 1s for patients not in the program. But we do see that looking at grade 3 placental pathology, we see that there's a significant increase in grade 3 pathology after development of this program. So significantly more acute pathology that we're seeing. When we look at maternal ICU admissions, we do see that there's a significant increase in maternal ICU admission after development of the PACC program. I will say, I think part of this is that we tend to be fairly conservative about who we admit to the ICU. And I think that sometimes we do it as a prophylactic measure rather than like truly meeting ICU level criteria. Similarly, looking at operative times, we see that there is a significant increase in operative times after development of the PACC. I think part of this is that we're seeing more planned cases, which often take longer. And then also we use ureteral stents for all of them. So all of these patients have a pre-op cysto with ureteral stent placement, and then also have a post-op cysto, which in review of the cases prior to 2021 was not always the case and adds a fair amount of surgical time to it. Looking at need for greater than 4 or more red blood cell transfusions, we see no difference between the two programs. And then when we look at complication rates, we see again, no difference between the two programs. And the complication rates includes both intraoperative surgical complications, such as injury to surrounding organs like ureteral or bladder damage, need for surgical reoperation related to the original case, and then also immediate, meaning less than 2 weeks post-operative complications, including both infection and thromboembolism, and we see no difference between the two. So when we summarize results, we're seeing a significant increase in the complexity of the surgical cases after the start of the PACC. See no difference in the EPDS scores, although they did trend lower for the PACC patients, although overall we're pretty low overall, which is good to see. Saw a significant increase in the pathology grade, significant increase in the operative time, significant increase in the ICU admissions, and then people are traveling a lot further from the hospital from home to the hospital to come here. But that's without any associated increase in surgical complications, need for massive blood transfusion, or an increase in depression scores. Looking at strengths and limitations. So strengths, these are all collected from a single center. There were no other major institutional changes at this time, so I think is a pretty good referral point. That being said, again, this is a single institutional center, so really can't be extrapolated to other areas and is really meant as more an evaluation of our program rather than necessarily applying this to other programs across the country. There's also really significant missing EPDS data, mostly because some of the referral hospitals don't use Epic, and so we just don't have access to them. I also was surprised at how many postpartum visits didn't have EPDS scores too, which surprised me. In conclusion, we successfully implemented an ACRETA program at our institution. We've expanded our referral database. And then despite significant increases in the complexity of cases, we haven't seen an increase in complications or depression. I'd like to thank Dr. Beninati and Dr. Lynn in particular, anesthesia providers, nursing staff, UW-MFM, Meriter L&D, all of you guys for being wonderful, bearing with us on these cases that can be tedious. And references, and if anybody has any questions.
Thanks, Erin. Thanks so much. This is super important work. And I just can't thank you enough for you and Mike working on this program, because I think it's really needed for our patients. I was wondering a little bit about the depression in the background population during the time of your study, because I think that would be a significant confounding variable.
Yeah, I think that is a good question. So interestingly, there have been studies that have shown that background rates of depression actually increase. So, right, COVID was underlying this entire time, which I didn't get into. I didn't control for that. We did look at whether patients had a personal history of depression and whether that impacted it. And once we controlled for that, it didn't make a difference. And, interestingly, overall rates of depression increased during COVID, but we didn't necessarily see that in our study. So certainly something to look at a little bit more. But again, teasing out whether people really had a personal history of depression was also really challenging. I've done chart review studies before, but not quite to this in depth. And this really highlighted how challenging it is to extract some of this data from chart review, particularly when you're looking everywhere and not just the Meriter charts. So it becomes challenging to look at it.
Great job. And you guys are doing great work for the patients that you serve. But I was curious, so like you looked at the depression and now you have an opportunity, you've created this center to prospectively track, data. So I think just a shout out to more of that in our department, because that would be powerful. But now that you didn't see a difference in depression, like, could you try, or do you have plans to try implementing extra support around mood? Or I don't know, I was curious about that, to then look to see like, oh, now we've implemented this mood thing, or maybe you'll actually then see an impact if you implement an intervention, is what I'm trying to say. So do you have plans for that?
Yeah. Thanks for bringing that up. So interestingly, when there's been some cool work done over the last couple of years at other programs looking at like depression and like obstetric trauma, not just accretas, but any sort of obstetrical trauma. And interestingly, anxiety actually correlates higher with that than depression does. I was hoping to be able, you can actually tease out some of the questions in the EPDS, get at anxiety. And so if you look specifically at those questions, you can get a little bit at the anxiety. Unfortunately, there were the only patients that I could see the specific EPDS questions for were patients that were seen in our clinic, and there weren't enough to actually analyze it. So I wasn't able to get at any of the anxiety. But that has been shown to definitely be true and be associated. And so, I mean, big picture, I would really like to see that we have a mental health care provider that is plugged in and part of this team and part of the routine referral, both antenatally, because I think, you know, what a lot of the data has shown is that counseling and expectation setting is a big part of this, which we can do some of as the surgical team. And I think that we do a pretty good job of that. But certainly there's a lot more that can be done by healthcare, mental health professionals, but then also really postpartum and just standardizing that. So rather than having it be something where people have to reach out and ask for help, they just are standardly referred. Ideally, it would be in our clinic. That's really challenging. Meritor situation. So I think figuring out how we do that will be the biggest challenge. But there are several providers within the UW system who have expressed interest in helping with that piece of it. And so I think setting that up so that it's just a standardized part of it. The other piece of this that I didn't get into much is that there's a lot of anxiety from partners as well and support people. And that has kind of been less well looked at. So I'd really like to implement a qualitative program where we actually interview both patients and their primary support person to try to get a better feel for where are the times and what are the things that are causing the most anxiety, so that we can actually really target these interventions to make things better for these patients moving forward. And then working with people closer to home, because so many of these patients are coming from far away, and we often see them at 2 weeks and at 6 weeks, and really they're going to need support and care for months to years to come after what some of these patients go through. So yeah, all of this was kind of done to sort of see where we're at, because I have a lot of thoughts about where to go with this in the next few years. Well, thanks everyone for listening. I really appreciate it.
Okay, good morning, and thank you to the department for giving us the opportunity to give our talk today. And thanks for being here, you guys. I don't have any relevant financial relationships to disclose. The objective for this presentation is to promote the surgical site infection prevention bundle that was implemented at our hospital to decrease the benign hysterectomy associated infection rates. As we all know, hysterectomy is one of the most performed procedures in the United States, and surgical site infection is reported up to 4.5%. The CDC monitors surgical site infections via the National Healthcare Safety Network, and it defines surgical site infection as an infection that occurs within 30 days after surgery that's associated with the part of the body where the surgery took place. Infections are classified as superficial, meaning involving the skin or subcutaneous tissue, or deep, meaning involving the muscles, fascia, or deeper organ spaces. For the purposes of reporting, the CDC does lump together abdominal hysterectomies as open and laparoscopic because it includes all procedures that involve incisions in the abdomen. And then vaginal hysterectomy is defined as a hysterectomy done through a natural opening, so only through the vagina. The CDC takes the collected hysterectomy infection data and reports it back to institutions as a standardized infection ratio. Basically, this measures the infection incidence. So the standardized infection ratio is calculated as the number of observed infections over the number of predicted infections that are calculated from a national baseline. The number of predicted infections is calculated using SSI probabilities from multivariate logistic regression models that are constructed from the CDC data during a baseline time period, and that represents a population's SSI experience. So because SIR is a ratio, if it's less than 1, then that indicates infection prevention. From 2018 to 2019, the CDC reported benign hysterectomy SIRs at our institution above 1.0, so above the expected population baseline. In response to this, we formed a multidisciplinary hysterectomy surgical site infection prevention work group. That was formed with the goal of maintaining all benign hysterectomy SIRs below the expected level of 1. The work group created an infection prevention bundle based on existing evidence from GYN, general surgery, and colorectal surgery literature. The bundle was designed to standardize pre, intra, and postoperative components, and to facilitate dissemination of the bundle and to help audit compliance, a checklist was created. This was an IRB exempt quality improvement study. So this is the hysterectomy SSI prevention bundle checklist, which many of you are really familiar with, so I'm not going to go over it in painful detail, but you can see that there's components at the pre-op clinics level, the AM admit, intra-op prior to incision, intra-op from incision to closure, and at the PACU level. The study included all hysterectomies for benign reasons prior to bundle implementation from October 2018 to September 2020, an N of 857, and all hysterectomies post-bundle implementation from January 2021 to September 2022, an N of 772. The quarter during which the bundle was implemented was excluded from the analysis. So most patient demographics and surgery characteristics were comparable between the two groups. Differences between the pre and post implementation groups were significant for increased laparoscopic hysterectomies and decreased vaginal hysterectomies, which follows national trends. An increased number of same-day discharges, which, as we know, was due to our hospital policy after COVID. Longer procedure duration by 13 minutes and younger age by 1 year. Before getting into the SIR data, I just want to remind everyone that the CDC obligates us grouping abdominal hysterectomies as open and laparoscopic, and then vaginal hysterectomies as a separate category. And then the CDC also doesn't separate outpatient SIR data by complex and superficial. So outpatient SIR is a component of total and complex and superficial data. So we looked at outpatient total and inpatient total SIRs together, but then we also lumped out inpatient complex SIR since that has implications for morbidity and mortality. Statistically significant improvements in benign hysterectomy SIR were noted for outpatient abdominal hysterectomy, inpatient vaginal hysterectomy, and inpatient complex categories. While not statistically significant, it is important to note that outpatient vaginal hysterectomy SIR remains stable at 0. And inpatient abdominal hysterectomy improved to 0.443 or below the goal of 1. Overall, benign hysterectomy SIR has improved to below 1 after bundle implementation. This graphic looks a little blurry, but essentially this is looking at our 4-year time period. The red line indicates the SIR goal of 1. You can see when the bundle was implemented. Abdominal hysterectomy is represented by blue and vaginal hysterectomy by orange, and you can see that after bundle implementation, the trend is towards an SIR of 1 or below. So a strength of this study is full bundle implementation at one time period during which no other known perioperative changes were occurring. Due to full bundle implementation at one time period, pre and post groups could authentically be compared. Another strength is using the standardized infection ratios through the CDC to compare the pre and post groups, since SIR is risk adjusted for facility and patient level factors. There are a few limitations of this study. So all bundle components were implemented at one time. So it's imperative that when we're using these bundles, we're updating them regularly to continue evidence-based practice. Also, since this quality improvement project was focused on implementing a prevention bundle, we couldn't control for all factors like surgeon knowledge of being observed and changing their behaviors. And then finally, utilizing this data obligated us grouping together abdominal open hysterectomies and laparoscopic hysterectomies, which we wouldn't have done normally. But we did show improved SIRs despite that, so it likely just diminished our improved impact. To conclude, implementation of an evidence-based SSI prevention bundle at our community hospital sustained all benign hysterectomy SIRs to below the expected level of 1. So evidence-based bundle implementation is imperative. I want to acknowledge my colleagues on this project, and I'll take any questions.
Excellent work. I was curious, do you continue to look at your improvements or to look to see if it's maintained?
Yeah, we do. I have to take a look at that data again. I think over the last quarter, there was a slight increase in benign hysterectomy associated SIRs. And I don't know how much we've been using the bundle audit checklist or like what the compliance with it was for the most recent quarter, but we do look at it on a quarterly basis.
Gosh, that was great. I know that the CDC lumps both laparoscopic and abdominal together. Do you guys have the ability to separate that out and look at them individually, like a little bit more, and looking at like where some of the ones are coming from? Because I think, obviously especially for the abdominal ones, they're, I would say in some cases, probably inevitable. And so are you able to kind of get at that level of detail with what you have?
Yeah, that's an excellent point. I think that if we wanted to look at that separately, we just have to look at infections separately and not use the SIR, which then the only limit of that is then you're getting rid of those facility and other factors that they do the multivariate logistic regression for, which is nice for quality improvement project because you can't control for all those factors. So using an SIR makes that a stronger study. But that is an excellent point.
Dr. Jacks asks, the UW has a database that collects the bacterial culture results for each infection as well in SSI. Do we also collect that data?
Yes, the CDC looks at that data because we report it out to the CDC. And then they look at antibiotics prescribed for like superficial infections that may not have been cultured. Thank you.
Okay. I'll just set this here. Can everyone hear me? Yeah. So my name is Matt. I'm one of the GynOnc fellows. I'm going to be talking about a project that I've been working on with some people in our division and the Division of Laboratory Medicine and Pathology. I'm going to give a little bit of background just on the project itself, just because it has to do with some changes in endometrial cancer sort of staging and prognostication, and then I'll talk about the project in general. So I don't have any specific disclosures. So many of us are familiar with the dichotomy that has classically been used to describe endometrial cancers, grouping them into type 1 endometrial cancers, which are typically considered low grade, estrogen dependent, what we sort of think of when we think of someone that has an endometrial cancer diagnosis, and type 2, which are considered estrogen independent, more aggressive. Typically, those are your like serous and clear cell histologies. So recently, it's become evident that this classification is a little too simple, and like a lot of other dichotomies and binaries has started to fail to really explain how to describe this really heterogeneous group of cancers. So this has started to fall out of favor and be replaced by molecular diagnostics, which are now being more so incorporated in prospective evidence for how we should manage and take care of endometrial cancer patients. Oh, okay, forgot that. Anyways. So in 2013, the Cancer Genomic Atlas Research Network categorized over 300 endometrial cancer tissue samples using whole exome sequencing. They then reported out these graphs here, which you can see describe 4 separate clusters or groups of patients with different survival outcomes based on the molecular data that they were able to abstract. They then correlated these molecular alterations with common endometrial cancer histologies and postulated that integrating these molecular definitions into prognostic methods could further personalize medicine in this space. The 4 groups that they described and are shown here are POLE ultramutated, which is this line up here, this like solid blue one, that's the best. And then as you work your way down, you have microsatellite unstable. Those are your like DMMR, mismatch repair deficient patients. And then copy number low and copy number high. And copy number high being this red line, which has the worst survival. Since this publication, over 10,000 research articles have been published regarding the exploration of integrating this into endometrial cancer diagnosis and management. And so I'm here to talk to you today about our 10,001 project. These groups were then proposed to be sorted out by an algorithm from TCGA into how you could necessarily work this into a diagnostic or a prognostic flow sheet when you're managing a patient. It's not practical to do next-gen sequencing on every single person that has endometrial cancer. And so this was quickly, people started to work on what are ways that we could do this in a way that is practical and applicable and sort of able to be distributed to every single place on earth that is taking care of these patients. And so then about a year later, the proactive molecular risk classifier for endometrial cancer, which has become known as PROMIS, came on the scene. And they essentially did the same thing, but they started to correlate these groups with in-house tests, immunohistochemistry that we have available here, and then a little bit of next-gen sequencing, essentially to replicate this in a way that was reproducible and feasible for a lot of institutions. The names of these groups were then slightly altered. So we end up with this POLE subgroup again, MMRD, which is that MSI group, P53 abnormal, which is the copy number high, they're the worst. And then this NSMP, no specific molecular profile, which is kind of an intermediate group. And it means that we don't really know what to do with those people, or we don't know how to classify them any further than that. So now this has kind of become a hot topic in endometrial cancer, and we're starting to see very early research that is showing that specific types of treatments might benefit some of these groups more so than others, and is starting to move the needle into a more personalized medicine for these patients, which is great. Okay, so why does this matter? So this, well, that looks like crap. Okay, so this is a figure from a recent article that was published in the Green Journal, highlighting disparities along the continuum for endometrial cancer patients as they approach treatment and diagnosis for endometrial cancer. So as many of us know, this is not a new issue. Reproductive justice in endometrial cancer has been a problem forever. However, we are now starting to describe where all of these problems are contributing to worse outcomes for endometrial cancer patients. Within the next 5 years, endometrial cancer is set to become the deadliest gynecologic cancer and surpass ovarian cancer for the first time. And much of the research in this space has focused on how do we increase timeliness to diagnosis, timeliness to referral, timeliness to treatment. But there has not been a lot of research focused on what are we doing, particularly with the integration of molecular data into making personalized treatment decisions, making personalized staging, surgical decisions. And so that is what we wanted to do with this project. So to summarize, this molecular data is very interesting. This molecular data has important prognostic implications, and this molecular data could help us determine ways to make personalized medicine more individual, and ideally then start to back away from some of the like blanket ways that we stage, approach patients with treatment decisions, et cetera, to come up with a more personalized plan that might be able to address disparities on the staging and treatment side of things. So what I was particularly interested in is how do these molecular groups present in terms of advanced disease? So when you have someone who has a new endometrial cancer diagnosis and they have disease that's outside the uterus, do these molecular groups present with different patterns in the abdomen, different patterns in the body? And do they recur in different ways? Are you more likely to have someone with a DMMR cancer recur just in the pelvis, just in the lymph nodes, or just in some other place relative to P53 abnormal cancers or this NSMP group? So we hypothesized that patterns of metastatic spread and disease recurrence would differ between these two groups, DMMR and P53 abnormal. We chose to focus on this specifically because these two cancers in the PROMIS molecular classifier have the worst overall survival. And they're also routinely sort of surveyed here. And so it'd be something that would be very easy to just sort of evaluate with our own patient population. So what we did was we used archival pathologic tissue samples from our institution, and we assembled a tissue microanalysis and performed serial immunohistochemistry stains for common endometrial cancer markers that included the estrogen, progesterone receptors, HER2 amplification, P53, and MMR proteins. All the patients underwent surgical evaluation at UW, meaning that they had surgical staging completed or debulking completed here, and they had at least 5 years of follow-up data so that we could evaluate their recurrence risk and where that happened. We extracted clinical data from the EMR and performed statistical analysis for categorical and continuous variables, and multivariate logistic regression was used to assess these different patterns based on variables that were significant in our univariate analysis. Okay. So we defined these metastatic groups 2 different ways. So one of the first way that we did was by using a regional metastatic pattern. So where in the body did someone present with advanced disease and where in the body did someone recur? We described that as pelvic, lower abdominal, upper abdominal, and extra abdominal. These are the definitions here. The reason that we chose this was, one, we tried to focus on areas that could potentially alter treatment, whether or not you were going to decide to use something that was systemic based versus radiation versus surgery, et cetera. And then 2, we also applied this from data that has been done in this area in ovary, for example. So these groups were kind of abstracted from other papers that have looked at this similar question. For patients that then experienced intra-abdominal dissemination patterns, we categorized them into 3 specific groups: carcinomatosis, lymphatic recurrence, and then any type of visceral organ recurrence. These 3 groups are not mutually exclusive, but could potentially also inform how you would manage someone once they had developed advanced disease or recurred. Okay, so our results. So we included 380 patients. The majority of those had stage 1A disease. The most common histologies included here were grade 1 endometrioid and serous carcinoma, which was great because a lot of these prior studies that have tried to look at this have had really just only been focused in endometrioid histologies. On presentation, we identified 127 patients that had primary extrauterine disease. So that is disease that was classified as 3 or greater for stage, just for clarification. There were of those, and then after that, we also identified 128 patients that recurred. So there were in total 103 patients that were classified as mismatch repair deficient, 125 that were classified as P53 abnormal, and 153 that were that P53 wild type PMMR group. It's worth noting that these molecular groups come with varying sort of risk factors and differences in demographics, which were reflected in our data as well. So for example, our P53 abnormal group, they're more likely to be older, which is a risk factor for P53 associated cancers like serous and clear cell. They were more likely to have serous histologies, and they were more likely to be HER2 amplified, which is also something that is consistent with prior literature. The endometrioid predominant group, which is the P53 wild type, were more likely to be ER/PR positive relative to the others. And they were less likely to recur than the DMMR and the P53 abnormal group, which again fits with everything that we have seen thus far in terms of this classification. Okay, so among patients with primary metastatic disease, there weren't any significant differences between the P53 abnormal, DMMR, and P53 wild type groups. However, for patients with recurrence, P53 abnormal patients were more likely to experience upper abdominal recurrences compared to the DMMR and the P53 wild type, which kind of fits. It also kind of fits with what we have seen in regards to some of these other research studies that have tried to look at this, and that a lot of endometrial cancer still behaves very heterogeneously. And this kind of, again, I'll get to that, but it's drives home our point that this needs to be integrated into how we're making some of these decisions. So what was more interesting is that when we broke down the specific site that primary metastatic disease was identified, P53 abnormal patients were more likely to present with peritoneal-based disease as well as bowel or omental involvement when compared to DMMR or P53 wild-type patients. When evaluating for other gynecologic sites of spread, such as like the cervix, the vagina, the adnexa, things that are also included in our staging system currently, there weren't any significant differences between these three groups on primary presentation. In regards to recurrence, patients with DMMR cancers were more likely to experience pelvic nodal recurrences, and patients with P53 abnormal cancers were more likely to experience peritoneal-based recurrent disease, which is interesting. So then in regards to the intra-abdominal patterns that I mentioned, coupling this with the primary metastatic disease data that we had, there were, again, no significant differences regarding lymphatic spread, carcinomatosis, or solid organ metastasis. However, again, we see that for DMMR patients, they're more likely to experience lymph node recurrence, and P53 abnormal more likely to then represent with carcinomatosis compared to the other two groups. So this persisted in our multivariate analysis when we controlled for histology, primary and recurrent disease initial location, the adjuvant primary therapy that patients received, and then ER/PR status as well as HER2 status, which is, I think, really interesting. Okay, so this is all of this information integrated. I understand that this is a lot to look at. I will take some feedback on this chart later. The majority of the advanced abdominal disease here is largely belonging to the P53 abnormal group. This is in the primary setting. Serous carcinoma is well pelvic, which is largely represented by serous carcinoma. Pelvic and lower abdominal disease is more evenly dispersed amongst endometrioid histologies, which is represented by these three different shades of green. Whenever you switch to, or when we switch to the recurrent setting, the majority of extra abdominal and upper abdominal recurrences are dominated by those serous histologies, like I mentioned. And DMMR and P53 wild type tumors are particularly represented among endometrioid histologies as well as other high-grade histotypes. So the interplay of this data then highlights the interconnectedness of these forms of classification and how unique each of these endometrial cancer patients could then potentially be managed with the integration of this data. So in summary, molecular classification, particularly in P53 abnormal and DMMR endometrial cancers, does identify unique metastatic and recurrence patterns. Patients with P53 abnormal endometrial cancers are more likely to present with peritoneal-based disease and experience peritoneal-based recurrence, where DMMR cancers are more likely to experience lymphatic recurrences. This information could be used, like I mentioned, to develop intentional prospective studies that could incorporate molecular testing into surgical staging and therapeutic trials that could then be tailored to the individual and their specific cancer. These are my references. Dr. McGregor has been really the champion of this project, and Eric Reitz, who's a medical student, has been great, and I'm very appreciative to them for taking this on with me. Dr. Barillette, Dr. Wallace, and Dr. Alniami have also all been very helpful and kind of provided a lot of perspective on this project. And Dr. Dandy Wong and Dr. MJ Gao also have worked on various iterations of this microanalysis in the past and contributed some data to this, so I appreciate them as well. Yeah, so the issue with this right now is that there's a ton of observational retrospective data regarding molecular classification in endometrial cancer, which is great. However, we know that we can't change practice and change the way that we do things just based on retrospective data, because that's problematic. So what's been happening is that now in clinical trials, we are seeing an increase in clinical trials that are biomarker directed, that are focusing on DMMR patients, or that are focusing on P53 wild type or P53 abnormal patients. Or if they're not doing that, they're substratifying their results to say, you know, this wasn't significant. This didn't really change progression-free survival. It didn't change overall survival. But when you look at just this subgroup of molecular classifiers, it did. And so maybe we need to specifically investigate that treatment or that intervention in that group. That is only really just now in the last like year or so started to produce some results that are changing the way that we are treating and managing some of these patients. So for example, earlier this year, there was a study that was published in the New England Journal that demonstrated that immunotherapy with pembrolizumab is beneficial, particularly for patients that are DMMR positive. And so that has like rapidly changed how we are starting to manage some of those patients. The issue with that is that obviously that takes a very long time. Those studies can only accrue so quickly. And so a lot of this we're still kind of waiting on. Other institutions have been more quick, I guess, to take up some of this prognostic data and implement it into treatment making decisions. And you could go back and forth as to whether or not that's ready for prime time. We have not done that here because of all those reasons that I mentioned. And also some of the stuff like the POLE sequencing, all of that is very expensive and tedious and hard to do on every single person with endometrial cancer. So there are still some practical considerations here, but it's happening. It's just slow.
Great job, Dr. Wagner. I have a quick question about like the classifications and molecular classifications. They're not quick enough to do them intra-op, correct? So like these would all be afterwards. So I guess, do you think there'd ever be the ability to like make surgical decision-making on staging or other things you would do for that with those classifications in the future?
Yeah.
Maybe? Or now or?
Yeah, so you're right. So they can do like they could throw on a P53 IHC or something like that intra-op. The nice thing about this is that this has been reliably reproduced on endometrial biopsies, so it is something that can be obtained preoperatively. Even the POLE sequencing really doesn't take a lot of data because they're particularly looking for just like a couple of little hotspot mutations. So my hope would be that everyone would have an endometrial biopsy, they would have a molecular classifier, they would come to our clinic and we would say, this is the surgery you need. These are probably your treatment options afterwards. We know that these ones are not going to work as well. And we send people down that path with the integration of stage and histology and some of these other things.
That was awesome. This is, I haven't thought about this in a while. In terms of just going back to your slide about disparities, have you been able to tell, or is there literature looking at, you know, we have the advantage of like wonderful pathologists and a like great program here, but obviously a lot of these endometrial biopsies are being done at community centers without access to all of that. How much of this molecular testing is able to be done outside of academic institutions, or is it all now being sent to major centers, or do we know anything about that?
Yeah, so as far as the molecular groupings that we have available to us now, all of them should be able to be done at any institution. The only thing that is a hang up right now is this POLE sequencing, which a lot of people are struggling with because it's currently a send out. It's something that's really expensive. There's not an in-house probe. So a lot of people have looked into, for example, when we do HPV-based testing for like 16, 18, et cetera, that's just a probe that looks for certain sequences. You just throw on there, it's IHC. So could you do that for POLE? Can we get that set up? That could make that widely available. That has not really caught on because the POLE group has such great outcomes that some people are like, well, why should we even look for this? Most of them are stage 1. Most of them never recur. But to answer your question, yes, these are all tests that should be able to be, that anyone could do anywhere. One of the arguments for the integration of this is that histology in endometrial cancer in particular is very subjective. So someone might have like a grade 1 endometrioid on outside path that then comes to a different institution in another clear cell. And that's obviously very different. The integration of molecular data into that could help you further substratify that patient's risk. So the fact that it is relatively able to be applied or performed at a lot of different institutions is really appealing. People are just resistant because it's more testing. It doesn't reimburse any more than if you just call something endometrioid or call something serous. And, you know, more importantly, we don't have prospective data to say that this is actually helpful yet. So. All right, thanks.